It's a sponsored session by Merrill, and we'll be talking about mostly the Myval THV series. My name is Andreas Baumbach. I'm from London in the United Kingdom. The objectives as they've been written is to learn from the practitioners, from the experts about TAVI practice. We'll see some interesting cases, discover more about the clinical updates from the large two randomized trials, and to know about the novel Myval THV series, key features, procedural impact, and potential clinical benefits. This has changed around a little, but with me is Khaled Al-Meri. He's the spokesperson, and eventually we'll have Myval THV, Mohammed Al-Hichi, Imad Al-Haddad, Walid Al-Harbi, Ata Firuzi, and Fadi Savaya here as discussants. Now, without further ado, I'm going to kick us off with the latest clinical updates from two large randomized trials. That's me. Now, just a show of hands, who has used a Myval for TAVI? Okay, right, very good. Now, this is now not anymore the new kid on the block. It may be one of the newer valves, but there have been worldwide about 44,000 implants, 126 publications, 6,000 patients in studies, and it's available pretty much everywhere on this globe. And as you know, one of the unique selling points here of the Myval is the intermediate sizes. So the size range is much larger than with other models. We go from 20 via 21.5, 23, 24.5, all the way up to 32. And here in India, there's even a larger model available. And that compares to the other valves here that were used in the landmark trial. The landmark trial, and I was the principal investigator, Patrick Serois was the study chairman, an effort mostly in Europe, was a randomized trial where we compared the Myval THV series versus contemporary, and contemporary was made up of Evolute series and Sapien series. The initial results were published in the Lancet. The primary composite endpoint at 30 days was reached in 25% in the Myval series, a big composite endpoint, and 27 in the Sapien, and it was non-inferior at 30 days. And here you can see 16 countries participated, so mainly Europe, but also in Brazil and New Zealand. We then opened that up and looked individually in Myval versus Sapien and Myval versus Evolute, and in both cases there were no relevant clinical differences, and the non-inferiority was also confirmed in these powered sub-analyses, and that was published by Niels van Rooyen, who was one of the major implanters. And then we have Denmark, where 3 centers went ahead and did a Compare TAVI study, starting before the pandemic, with a break, not only through the pandemic, but also some legal issues. And we will see both elements of that series. But they enrolled in eventually 1,000 patients, 1,032, and they compared the Myval series versus Sapien in this all-comer study. What they found, they had another endpoint, but again, Myval was non-inferior to Sapien for the primary composite endpoint at 1 year, and the primary endpoint was a composite of death, stroke, moderate or severe AR, and moderate or severe THV deterioration, and that was according to VARC-3, which is an important criterion. So what's new? We have 1 year results, and again, a landmark was done according to VARC-3, And that is a very arduous undertaking. We need a lot of work from the Clinical Events Committee because they have to determine the various forms of valve dysfunction, deterioration, and of course all the events are assessed. But this is basically it. At 1 year between the contemporary series, which is made out of the self-expanding and the balloon expander on the market, and the Myval in green, there's absolutely nothing between them. So comparable composite clinical efficacy at 1 year. Echocardiograms, we had collab, and this was available in 93%, and you can see that in the Myval series, we have a really low mean gradient, and this is comparable between the two series, and also the effective orifice area at 1 year. Here it looks as if there's nothing between them, but we can actually see in most of the sizes a slightly better outcome for the Myval versus the balloon expandable. The occurrence of moderate or severe aortic regurgitation was comparable again between the two arms. Now there's combined data. So the title of my talk is New, What's New? So this again was published and presented earlier this year. And we put together the Compare TAVI data. Again, Compare TAVI is SAPIEN versus Myval, and the landmark part of the trial that compared, that used SAPIEN. We had one composite endpoint. We adjusted that according to the Compare TAVI, and we did some subgroup analysis. So this is how it looks. We end up with 718 patients in the as treated for the SAPIEN and 872 in the Myval. And they are made out of two. We will see about the valves in a moment, but they were made out of the first Myval and also Myval octa-core in 356 patients down here. And essentially, if you look at this study, these are all-comer patients from their risk profile. You can see individually the composite endpoint, there's no difference, and most of the individual endpoints do not show any meaningful difference. With one exception, and a lot has been made of that, we can discuss that. There seems to be a higher pacemaker rate in the favoring the SAPIEN, a higher pacemaker rate in the Myval group. Hemodynamics, effective orifice area, and that's what I alluded to. These are the two balloon expandables, so SAPIEN in red and Myval in blue. There's a larger effective orifice area at 30 days and 1 year. And if you look between Myval and Myval octa-core, there's nothing much between them. And the same is true for the gradients. That's basically the other way around, peak gradient and mean gradient. Overall, that's across the spectrum of annuli treated, mean gradients of around 10 and 8. This is what I meant before. Mainly this experience with higher pacemaker rates comes from the Compare TAVI study. And there we can see a clear difference between the octa-core and the Myval. And there are some technical explanations as to how that could have come to pass. At the moment, we're looking into registry data, and we don't see such high pacemaker rates in clinical practice, actually. This is just another illustration of the effective orifice area, and you can see the SAPIEN in blue and the deviations here slightly improved for the Myval and Myval octa-core. And we all know now the SAPIEN is now the RESILIA, and we also have published data to show that the RESILIA has more or less caught up. So the effective orifice area there these days is comparable. And finally, we've got 3-year outcomes of the first part of the Compare TAVI study, and they looked at their composite endpoint, in 192 and 187 patients, nearly 200 patients now, in a randomized comparison. And death at 3 years is no different, and neither is there any difference in the primary composite endpoint or the stroke or moderate to severe aortic regurgitation. So basically, at 3 years, Myval and SAPIEN 3 or Ultra are comparable regarding death, stroke, moderate or severe aortic regurgitation, moderate to severe hemodynamic THV deterioration. Basically, the same clinically. We'll watch this out to 10 years, but for now, it's very reassuring that the 1-year results are confirmed at 3 years. Yeah, watch this space. Thank you very much. And I think Russia is now your turn.
Thank you very much for the invitation. So the next presentation will be on the latest in terms of transcatheter aortic valve platform, as well as other transcatheter therapy by Mero. So we know that TAVI is the main procedure done in transcatheter field, and it's definitely growing, and we're adding Myval series to the growing number of platforms. So the initial Myval design, as some of you are familiar with it, as you know, it's a balloon expandable valve. It has an inflow and outflow. If you look at the inflow part, it has closed cells, and it was about 47%, as the outflow is about 53%. But the main difference that you're going to see in the newer version is that the skirt here is smaller than the skirt that you'll see in the next slides. But the main advantage of Myval, as we all know, is the fact that they have lots of sizes, including the intermediate sizes and the extra large sizes, which was the main advantage over the other available platforms. So here are the sizes that we were talking about, intermediate and XL, that were at some point not available in other platforms. And these are not uncommon sizes. So if you look at the landmark trials, almost about half of those were actually in the intermediate sizing. So as many other studies that looked into this, we're looking at 40 to 50% that needed that intermediate sizing. So when you look at some hemodynamics performance, some of it is already covered by Andreas, that compared to SAPIEN, there might have been better performance in terms of patient prosthesis mismatch, but it's only in the moderate phase, but no significant difference in terms of severe patient prosthesis mismatch compared to self-expandable valves. So what's new with OctoCore, and then we'll cover OctoPro in a second. So OctoCore wanted to address paravalvular leak, so they had a bigger skirt, helping in terms of that increasing the seal and decreasing risk of paravalvular leak. The other thing is that they also had that interlacing octagons, so also for stability and more, or I would say less foreshortening. So the initial foreshortening was more than 24%, and with this OctoCore version, it's about up to 20%. They still maintained their intermediate sizes and extra large sizes, but it was more predictable deployment with less foreshortening. What do we know with OctoCore? Most of the data that was initially done was mostly with Myval, but with OctoCore there are some data. This was a registry data, so propensity scored match data that what they did is they actually look at NeoPro 2 registry patients, including Evolute Pro and Pro Plus, as well as Accurate Neo, and compared them to prospective registry of OctoCore of about 252 patients. And then they did propensity score matching, took about 90 patients in each arm, and they looked at 30-day VARC device success. And what they found is that there was statistically significant performance benefit with OctoCore, and was mainly driven by less moderate to severe paravalvular leak. Now, I know this is a registry data, so we have to be careful interpreting some of those results, but it kind of reassures us that OctoCore might be even performing better than the previous generation of Myval. The other thing that they've noticed is that there's a better effective orifice area as well indexed. So what's new in terms of Myral? So in terms of aortic, there is a newer platform, which is OctaPro. There's also other transcatheter therapy that we're going to discuss in a second, including pulmonary and mitral. So with OctaPro, what they did is that they made the covered part actually smaller, so 45% in the inflow. But the main thing is the unique design that is shaped more like a V on top. This will eliminate less of the foreshortening. So the foreshortening in this platform is about 10 to 12%. So again, more precise deployment and less and more stability during deployment. It comes with the same sizes, intermediate and extra large sizes. So moving on to pulmonic valve, there are numerous cases of the use of Myval in the pulmonic position, and it's attractive, as we said, because of the sizing. But there's also a dedicated valve designed by Myral, and their idea is that to have a completely sealed device, both inflow and outflow. It does have the same idea of the skirt with less paravalvular leak, and it comes with the larger sizes that sometimes are not available for certain patients that we need. The other thing that we'll finally mention is also, aside from valves, there's also tier options that are being designed by Myral, and this is a MyClip tier system. It's approved in India. This and the Pulmo are approved in India. No data yet to show non-inferiority, but we'll wait to see, I guess, more data to show their non-inferiority to current platform. But it has similar design to what we're seeing in other mitral tier, with different sizes of clips and different and the same idea of a guide and a steerable guide as well, and the delivery system with the clip implanted on it. So there are more than 100 cases implanted in India, but we'll wait to get more results to show non-inferiority to current platform. So with that, we kind of summarize that, Myral is not just focusing on aortic valve, but other platforms. There are several generations of transcatheter aortic valve options, and the latest is going to be OctaPro. And aside from aortic valve, there's Pulmo THV, and there's MyClip, which is a mitral tier. Both hopefully will give us more options for patients, but we need more data, obviously. Thank you.
So we have seen how did Myval work or do in randomized trials. Now we'll see how does it do in real-world experience with Dr. Hassan Kalipur.
We'll have time for some questions after this talk. And if you have a question, you can use the app. It'll come up here, and we can read it out.
You need to do the warm up before giving a speech because here is too cold. This is a great pleasure to be here to share some different scenarios for TAVR procedure. I'm Dr. Ehsan from Rajai Center. We launched our Institute THV registry 5 years ago, and in the last 3 years we have performed over 1,000 TAVI cases, which were 43% of them with Myval THV. Our friends set the tone. Why Myval THV family? Because it is really a decent, flexible THV. It has gratifying trackability. Maneuverability is really sufficient to perform in any different anatomy. Passable pushability and a staggering skirt made it very suitable for diminishing paravalvular leakage, and its capacious sizings, no need for emphasizing on. And for the latest iteration, predictable foreshortening. This is our first case. We implanted in September 2020 in a 7-year-old gentleman with good final result. And yesterday, the patient came to the clinic for more assessment. And the TT showed still preserved LVEF, well-functioning THV with mean gradient of 12. And there was no signs of biprosthetic valve degeneration. The other case that I'm here to share is a 7-year-old man with a prior history of CABG 15 years ago. He was a known case of ischemic cardiomyopathy with LVEF of 10%. And he had a high gradient, severe bicuspid, severe symptomatic AS. And he was a known case of pulmonary hypertension. And lately, he was diagnosed with infrarenal AAA with recent growth and symptoms. Heart team discussion decided to perform the TAVI first, and everything relevant to the EVAR was on the table if anything happens. This is the TT before the procedure, showing a bicuspid anatomy with severe reduced LVEF. And we were pretty much lucky that the patient had a high gradient AS, and it could predict that the patient might have some recovery after the procedure. This is this CAT scan analysis with the anatomy, moderately calcified bicuspid. And we decided to precise sizing of this patient because it was very high risk. So we used also circular, ICD-4, and annular method. And finally, we decided to go for 27.5 Myval THV. And this is the anatomy of his infrarenal AAA. Firstly, we used a stiff wire to put the sheath, and after putting the sheath, we were pretty much confident to perform the procedure. This is the cine image before the procedure and implantation of the valve, and final acceptable result here. The day after the procedure, everything was good, and as we predicted, the LVEF increased to 30%. So my friend could perform the EVAR without any difficulties. And this is the chest X-ray. Always I show to the residents to find all the devices and accessory on this patient, and mostly they missed the EVAR device. The next case is a 7-year-old lady with prior CABG 10 years ago, which presented to the clinic with reduced LVEF lately with severe aortic regurgitation on the echo. We assessed patients for more evaluation, and as the echo and CT showed, there was some minimal calcification over the aortic valve, and regurgitative was the nature of this valve dysfunction. And as the perimeter showed, it was 500 on the average, so we decided to go for 25% oversizing for the TAVI procedure. And this is the CAG, which showed patent lima with some disease, and this is the procedure. And we decided to go for very slow, gradual inflation of the valve, and successfully we could just implant the valve without any other difficulty. And this is the final angiographic results. And the last case was 78 years old man with prior history of CABG by prosthetic AVR in 2016 with mitral flow 25 valve, and he lately presented to the clinic with degeneration of his bioprosthetic with reduced LVEF. We assessed patient for more assessment. Lima was patent, and this is the echocardiography of this degenerative bioprosthesis. And with mean gradient of 21. So this is the CT scan before the procedure. The inner ID was 21, 22. Safe VTC on the left and right side. And he had acceptable access. Based on the application, we decided to go for Myval 23 for this valve-in-valve procedure. Before the procedure, we decided to go for some modification of the bioprosthetic without doing the fracture, and final deployment of the valve with this acceptable result and mean gradient of 12. So we are here all for sharing some experience together. Why Myval? Because it showed versatility and it could be feasible in any different challenging scenarios. We need to be always as part of the heart team discussion, and sometimes functional recovery could be very fast and the patient would recover. We need more data about the durability of any THV valve, and I hope in future we will have one solution for each patient. Thank you very much.
Right, we've got time for one or two questions from the panel.
Question for you. What's your experience with the Octa Pro versus we have the original Myval, we don't have the Octa Pro, and from Europe, how do you compare both?
Yeah, I don't think I could, make much difference in the handling. Okay. It just handles as we have seen. All the elements are pretty much the same in terms of how you do it. The implantation has a different marker, of course, but we'll keep it high. Okay. But other than that, there's not much difference. Do we have a question from the audience?
What's the explanation for higher permanent pacemaker use? And you said there is technical issues. Can you elaborate on that?
So, we have, as you have seen in the registry just now, in that registry, the Octa Pro, I need to get them right, has got a pacemaker rate like the self-expanding 15%, and that's what we've seen in Landmark. So this, in the combined data, this was really driven by a very high pacemaker rate in the Octa Pro in the 3 hospitals in Denmark. And they have an explanation, actually. They say this was during COVID. There was no company representation, and they changed the valves, and they did not change the way they put them in. So they might have done them a little bit too deep. And there's a bigger skirt on the Octa Pro, and that could be the combined explanation. They're measuring everything. They're looking at implant depth and CTs and all of that. It's not entirely clear. All we know is that in clinical practice, it does not show.
Yeah, go ahead.
Unfortunately, we don't have Octa Pro in our country, in Iran. But with Myval, we published our first 92 cases in our center, and Dr. Bai maybe is here, and he reported, and the rate of complete heart block was 6.5, and 1 month's mortality in our patient was about 3.3, and 1 year assessment was assuring.
Excellent. Thank you.
We have a quick question here to
Okay, final question.
It's basically a question regarding the data we have, SAPIEN versus Myval. Mm-hmm. Has it been stratified according to the amount of calcification of the valve and eccentricity of the eccentricity index?
No, I'm afraid not. We haven't done that. I haven't seen those data. What we have tried is to come up with a fitting index, that is, the size of the implanted valve versus the annulus, and that's some interesting data, but we haven't done that. Shall we move on, Fadi? So this is now a recorded case. Dr. Fadi Savaya will show us in the next 20 minutes a very, very interesting case.
All right, these are my conflict of interest. That's starting. We're gonna show you a recorded live case with the Myval.
That was quick.
So we'll welcome you here from the American University of Beirut. We don't see the images though. I'm with my colleague Ziad Ghazal, and we're gonna We don't see the video. Okay. Show you a recorded live case with the Myval platform. So we're presenting here a 70-year-old guy who came into our clinic with dyspnea on exertion, and he came in for a workup. He had a valve area of 0.8, mean gradient of 20, and EF between 15 and 20%. He was sent to us by another institution. Past medical history was significant for a Tyrone David procedure with an aortic root graft, 28 millimeter, that was placed 2023, less than 2 years before the presentation. And he also had at that time coronary bypass grafting with the Lima to LAD and a vein graft to PDA. He did underwent a cath at the outside facility where it showed patent graft. So for those who don't know about the David procedure is valve-sparing procedure where you repair the aortic root with the graft, but you maintain the original valve. So you sew all the way the graft tube all the way down to the native sinuses, maintaining the integrity of the aortic valve. So we did a CT scan just to see if this is a low flow, low gradient AS, whether we see no calcification. But what we see is a very pinwheeled leaflet with some fibrosis and thrombus maybe on it. We did a whole scan, and what we saw is a lot of discrepant measurement. At the annulus, the area is 557. At the LVOT, the area is around 600. At the annulus, if you go up +2, you see this thrombus maybe with the area decreasing to 534. Annulus +4, you see a lot of maybe thrombi or fibrosis with the area of 440. And then the more you go up, you see anatomy that is increasing again. On the sinuses, you're back to 26 and 28 millimeter. You see no calcification. The left main height and the right coronary height were reimplanted very high, so there's no issues in this case. We got a deployment angle of a 3-cusp of LAO1 and cranial 9. The femoral iliac were non-calcified and not tortuous, which were good for TAVI. So we did dobutamine stress echo. If you look here on the left, the echo really is 15-20%. After 15 microgram of dobutamine, you can see how the LV became a bit more vigorous. We did a gradient at rest. We had a mean of 23 and a gradient at peak stress of mean 41 with the valve area that remained less than 0.8. So if you look at this case in general, it's very complex because one, there's no calcification. You have measurements that are very wide in the LVOT, wide at the annulus, where probably they sewn the pledged sutures, and it tapers down into the sinuses and it gets bigger again. So if you look at the LVOT, which is 2 millimeter below, you would choose a 29. If you look at the annulus, you would choose a 27.5. If you look at annular 0.4, you have 7.9% oversize for a 24.5, so we choose a 24.5. And so really not really easy to decide which measurement. So we decided our plan, hopefully today, we're gonna do this case under local anesthesia. We're gonna do an ultrasound guided puncture. We do 1 ProGlide plus minus angioseal. We're gonna put a pacer because the patient has right bundle. We're gonna go with the direct implant, and we're gonna try to go with the Myval 26, maybe with 1 or 2 cc more, we'll see.
Hi, we welcome you here from the American University of Beirut. We're happy to be joining the PCR Gulf Valve with the sponsored session by Merrill. We're presenting actually a very difficult case today. I'm really not sure why we chose this case for this live. We've discussed the case, you know, he had the history of Tyrone David procedure 2 years ago with bypass, Lima to LAD, and vein graft to PDA that were patent on a CAT done as an outside. He came to us with very low EF, 15%, with a question mark of severe AS. We did an echo here, and the valve area was 0.8 with a mean gradient of 20. On the CT, you see no calcification, but you see this wrinkled valve like it's been sewn the wrong way. So in order to be 100% sure that this is severe aortic stenosis, we did a dobutamine stress echo. And on dobutamine stress echo at 15 micrograms, the mean gradient was above 40 with the valve area remained at 0.8. And if you look here at the screen as well, we have a peak-to-peak of 40, 45, which goes as well with severe aortic stenosis. What we've done so far, we took access under fluoroscopy. We did our 3-cusp angle, which is around LAO20, caudal 8, which is very difficult because there's no calcium. And really the cusp on the CT scan were not really apparent. And really the anatomy is very weird because the LVOT is very wide, which goes with a 27.5 or a 29. But at the level where the graft was sewn with the leaflet, it's more like a 26. And then right above it is more like a 24 or a 26, and higher it's more like a 29. So we did a compromise. We don't want to take too large of a valve because if it doesn't open, we're going to have the same problem. We're taking the 26 and hoping this will anchor. We added 1 cc more, 1.5 cc more, and Ziad, we're gonna gauge if we give the whole extra cc's. We have our usual setup of left radial for our contralateral. We put a pacemaker, the patient has bifascicular block, right bundle, left anterior fascicular block, and we already crossed with the AL1 straight wire, and we have a pigtail. We don't want to wait too long, patient's not really stable. We're gonna go with the Safari, put the sheath, dilate the sheath, and then go directly with the valve with no pre-dilation. Here we took a Safari small because the ventricle is really, really large. We don't need an extra small. Now we're gonna go with the Phyton sheath. Fully awake, we didn't give him any sedation. Sure. Luckily, our femorals are good size to dilate the sheath with the 18 French in order to have a smoother passage of the valve. Okay, the 18 was able to dilate easily, so that's a good sign. The valve is gonna go in the sheath without any difficulties, I hope. And then we're gonna take our time with the advancement. Okay, this was very smooth. Okay. Okay, we're gonna take our time around the arch. There's a graft, so we wanna make sure it doesn't get stuck. Give me some rails here. Okay. Okay. No, 15 is good. Okay. Let's see here if I'm not at the outer curve, if I can adjust this. Let me see if I flex, this will adjust or not. Okay, you see, there's a lot of maneuvering we need to do here. The flexing did not help. Somebody hold the sheath for me, just it's coming back. Okay. Here. Okay. No calcium at all. There's a lot of movement. Ziad, just push on the wire a bit. Keep pushing, push, 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 push. Okay, just keep pushing here. Okay, I'm gonna restart from the top. Push on the wire a bit, but gently. Okay, I think that's not too bad here. Let's take an injection. Okay. I'm gonna just go a tad lower. Yeah, yeah. Okay, I think we can take it here, right? Let's space at 200. Inject. Yalla, Ziad, go up. Take your time. Yalla, go up, go up, go up, go up, go up, go up, all the way. One more, 2, 3, down, down, and off pacing. See how much constraint there is? He's bouncing back. Matati new, matati. Okay, pressure is fine. Ooh, we should probably take a 24.5 even. We're gonna probably do a second inflation just to make sure. I think it anchored not too beautiful, it anchored well. It just tells you how the sizing for these are a bit more challenging. I'm just gonna optimize it just in case we can get a bit more expansion. Okay, pacing 200. Okay, go up, yalla, go up. No need to increase, off negative. Okay, go up, go up, go up, go up. Okay, that's fine, Ziad. Off pacing, off pacing. That's fine. Okay, pressure is 130. That's, he never seen a blood pressure in 130 in his life for the last year. Inject. Okay, no AI at all. It looks perfect. And the position, I think, is perfect. I think we efface the sinuses. We don't see anything below. All right. Let's do an echo, please. The mean gradient is 10, okay? So that's fine. On fluoroscopy, on the pressure here, you see a gradient peak to peak of 5. Okay. Okay, so after zeroing our pressures, we have a peak of 7, okay? On echo, we have a mean of 10. I think this is very acceptable. I'm not gonna try to go take a non-compliant balloon to burst. I don't know if the tube is gonna burst or not, okay? I think we were lucky that the valve anchored. I don't know if a 24.5 would have been better, but it's very hard to predict these. I don't know. Okay, we closed the groin with pre-closure with 1 ProGlide, and we added an 8 French angioseal. This is our standard of practice. We're gonna leave the pacer till tomorrow because as a pre-existing right bundle, I think we're lucky that patient doesn't have a hard block on deployment because I think the LVOT is very wide, didn't touch. We have some minor under expansion of the valve, but the gradient mean is 10. Maximum tomorrow it will be 14 or 15, and that will be acceptable. Already the EF improved from 15 to like 30%. I'm glad this case went well. We had a graph. It's not a lot of cases. I looked at literature, just if 1 or 2 cases been done inside Tyrone David. Yeah, and also with all the wrinkling in this valve and look thrombi, we didn't have any neurological sequelae. Patient, we didn't give him any sedation, and he's happy that we're done. All right, enjoy the meeting, and thank you for having us.
Excellent case. Now, one thing stands out when you did the presentation, and that is the Tyrone David procedure. I had to look it up because our surgeons don't do that fancy kind of operation. And in this case, it doesn't seem to have done so well. 2 years?
Yeah, the issue, there was no problem with the aortic valve prior to the Tyrone David. So had a dilated aorta, normal. I went back and looked at the echo, had a normal leaflet and really no AS. I think the guy who did it is not very acquainted with this procedure, so I think it ended up damaging the leaflet, because if you look at the leaflet, they look pinwheel, they look like they were sewn wrong, and I think it was mainly thrombosis of the native leaflet that ended up with fibrosis and severe AS, which I've never seen before. And that's why the decision, if you look at it is wide, then it becomes tubular, and then goes wide again. And I had to ask the surgeon, what is the expansion of this graft? Because I need to, he said like it should not go more than 1 or 2 millimeter, and it was a 28. So, but even if you see the 26, looked like it was a bit underexpanded. So I'm glad I didn't take a 29 or 27.5.
Very nice. Also, I think it was a nice demonstration. I mean, the theme of this session is the Myval itself, and that's the first time we now have seen one go in. Maybe we go through some of the features. You don't have to flex because it's very, very flexible. Some say the lack of a pusher gives you less pushability. Is that true?
Yes, maybe if you have a lot of calcium. I mean, if I have a lot of calcium, I like to predilate, which is probably not the practice of everyone. But the good thing that you can, if you cannot push, you can remove the valve and just do another predilation, which is not feasible with the other balloon expandable. I think one of the feature also I like to predilate my sheath from the get-go, regardless of the size of the valve. I'm predilating all the cases. It makes pushing through the sheath.
To explain, you just use a larger dilator.
Yes.
So the sheath goes in relatively small and easy, and then you open it up because it's expandable. And that is just simply to enable a smoother transition of the valve system, and I don't think there's any risk of losing the valve anymore. That might have been the very, very early days, but it's just easier to go through. Ima, you look as if you have a question.
Well, from the way the valve expanded, it looks like it is a fibrosis. But if you have a thrombus on the valve, how do you approach that? I think it would be risky to implant a valve when you have a thrombus on the leaflets. So would you treat it for some time before you do the TAVI, or what do you do?
I think it was a chronic process that started at thrombosis, ended up with fibrosis. Patient got NOAC before and things didn't change. He had a normal EF. Diagnosis of severe AS was done 6 months prior to patient presented to me. EF was normal, and 4 or 5 months later, the EF started to drop. So I think it was already in the fibrosis. And for financial reason for this patient, we did not use a protection device, although the data on it is not very convenient. But this case, probably it was more prudent to use one.
Okay.
Yeah. I have a problem with this valve. I have seen it in all the 3 cases, and maybe you can help me sorting this out. It's the balloon. For me, there is an issue with the balloon. There is an proximal port and a distal port, and it ends up with a duct boning, and the stent is very rigid, so there is no way to adjust it. That's my interpretation of the image. So for me, the duct boning is not ideal. So do you see from your experience anything different? Because when you inflate distal and proximal balloon, and the stent stuck in the middle, you cannot adjust it. So how can we adjust it? I think this is, for me, this is a disadvantage.
Honestly, I haven't had a lot of problem. I've had 0 embolization with this valve. Yes, that's why I take my time during deployment. You see, I inflate a bit, make sure it's stable, there's no pacing, and then I go all the way. If you're gonna go very fast, yes, you're not gonna be able to adjust just because of the inflation from the top and the bottom of the balloon compared to Sapien, where it inflates from the bottom first and then you can adjust. But honestly, I haven't had a problem with adjustment. I'm not sure if anybody has a different experience.
I think one of the ways to implant this valve you have demonstrated quite nicely is you can take your time, because you can adjust, and it sometimes wants to go in a little. That's why we make it a rule to have before the deployment, the last movement is backwards to take all the slack out. But that's the only thing. Other than that, we didn't have any problems with that. Are there any further questions from the audience? We don't have anything.
Question here.
There's a microphone at this.
There is a mic there.
Please take your time. It's fine.
Yeah, I have noticed that he was having issue with coaxiality of the valve. For example, in Sapien, we can address this by the knob, but you were pushing the wire. And the balloon, when it's expanded with Sapien, it helps the LVOT coaxiality. How, with this short balloon, how is your experience?
Yeah, I mean, usually when you flex, a lot of the time it does centralize. In this case, it didn't. I think it's partly because of the anatomy and there's a graft. One of the options, you can take a stiffer wire like a Lunderquist and it can adjust. But here, I wasn't afraid to push the wire. Patient had bypass surgery before, so I just went up, told my second operator to push on the wire, and I just push a bit, and then it went to the outer curve easily. Even with Edward, sometimes you take time to adjust, so I don't just, if I'm not coaxial, I take my time, I play with the wheel, I play with the height, and then it's no issue with alignment with this case. And half of the time, it just centralizes alone after you start deploying.
Thank you.
And I think in terms of flex, it has to be said that you can bend it almost back on yourself. So if you want to, you can.
I tried it, but it didn't work, so I went to my second technique.
One more, yep.
Thank you, Dr. Swai. This is Dr. Rashid, and I'm a cardiac surgeon. Just want to shed light on the Taron David procedure, because I think people have to understand why this valve failed. If you look at the idea of this, you cut the sinuses and then you go all the way down and you implant the graft subannular, actually. That's why you see the annulus itself is restricted at. And then the annulus goes a little bit narrow and then it wide again. So I believe this operation failed because of 2 reasons. Reason number 1, the graft of the size was small. So that's why the valve itself, it become a little bit restricted and the valve get thrombosed. Usually these, I've seen these cases comes back, but if they comes back, they don't come back usually with aortic stenosis. They come back with aortic regurgitation. But this is very early degeneration. In 2 years to see this case, it's a little bit concerning. And I believe most of these cases, we end up doing the redo operation on them. We give them a biological valve. Then in future, if they're going to come for a TAVI, they will come for valve and valve. But I think this is a great platform of such like a failure graft and the failure valve early. But I believe these cases still need to be tackled surgery. But maybe the reason why you operated on him or you did TAVI because his disc fracture was a little bit
yeah, he was,
and the surgeon was maybe hesitant to touch the patient.
Yeah, he was like low EF, elderly, he was a bit frail, some kidney dysfunction, admitted multiple times with heart failure. I don't think anybody wanted to touch him. Even I was reluctant with like, I didn't understand the anatomy well, and I was worried like the valve is gonna pop
because
up.
If you look at the data, Taron David presented his data. The valve freedom from degeneration at 20 years was 95%. But the problem is the standardization of the procedure. A lot of centers try to do it, but they don't end up doing an excellent outcome. So the patient come back with degenerative valve.
Thank you.
Perfect.
It's always nice to have a surgeon in the audience.
Absolutely.
Yeah. Next speaker is Myval. She will tell us how does this valve work in our population specifically.
Difficult to follow, Fadi. All right, so I'm going to talk about from evidence to practice and looking at real-world experience from the transcatheter heart valve, particularly in our part of the world and Saudi Arabia, to be very specific. I don't have any conflicts of interest, including this presentation. So we've heard earlier this afternoon about the landmark and Compare TAVI trials from Professor Bombach. We learned about the efficiency and safety of the Myval. We have long-term outcomes, which really is prompting us to go ahead and use this platform in mainstream. Likewise, the Compare TAVI showed that it is comparable and non-inferior to current balloon expandable platforms. But we have to recognize that we do have limited data for a very complex population in the Gulf region in the Middle East. We did publish the Gulf TAVR registry. We looked at all the Gulf TAVR patients. We also looked at a sex-specific sub-analysis of these patients. What we do know is, very carefully we look at these patients, we do know that their mean age was in the 70s, 74, so they were quite young compared with Landmark and Compare TAVI. Their STS score, however, was higher. NYHA class 3 and 4 was actually more than the Landmark and Compare TAVI trials. More diabetics were seen in our patient population, and certainly more baseline coronary artery disease in our patient population, including those who had undergone prior revascularization, be it PCI or CABG. And so what we are looking at in the Middle East and in the Gulf region is a very complex population with many comorbidities. Frailty was the #1 indication for these patients. And of course, concomitant coronary artery disease. And when we look at women compared with men, what we do see is that women tended to do better, although their cardiac rehospitalizations were in fact higher than men, and we need to explore that a little further, and I'll show you a few examples. In Saudi Arabia, as of 2025, we have close to 350 patients. There is an ongoing registry that is Saudi FDA approved and includes the major centers in the kingdom. So I'll show you some very real-world cases. These are from our center. This is an 82-year-old woman with severe symptomatic aortic stenosis. She had near syncope 2 times prior to the procedure. STS score 4.1. I'll show you very quickly her echocardiogram. You see her peak gradient over 80, and you do see significant LVH, normal LV function otherwise. This is her CT parameters. You do see the left coronary height was very good. The right coronary is not appearing, but it was also quite negligible. But you do see that she had a small LVOT, and the area was actually pretty small as well. Her vessels, surprisingly, were what we consider okay in our part of the world, 6.6, 8.0, and so on. We've seen even earlier today much smaller peripheral vascular disease in our patients. So we went ahead and deployed this valve. This was her tricuspid, the annular projection. And you see we managed to deploy it, and what you do see over here is this is the leaflet measurement, and you do see that we were well below the left main ostium, and so we felt safe doing it. The cinching of the peripheral was actually dilated subsequently, but what you do see with the echocardiogram is that our gradients were actually very good, mean gradient of only 3, no aliasing or anything across the valve, and it's well positioned. But this is her echo prior to discharge. So although the valve has been implanted, you do see why she may have had near syncope. And so there's more work for us to do in this woman. And certainly we need to slow down her heart rate. We certainly need to look into that LVH and potential HOCM physiology. Another patient, this is a 71-year-old gentleman, again symptomatic, STS score 2.0. Now, this is the interesting part, is you look at the left coronary artery 7, right coronary artery 13, the rest of the parameters, particularly when you look at the sinuses, they're fairly generous. But more than that, so you want to consider here coronary protection versus not, and so on with this kind of left coronary height. But you do see generous sinuses, and more than that, you have to measure the leaflets. And if the leaflets are okay, then you're probably okay deploying a valve here. And this is, I'm trying to show you that we did deploy the valve safely. You don't actually need wire protection. And I'm sure there's a session that's coming up here at Gulf PCR Valve where they're going to be discussing who are the cases that need protection versus not. There was a waist, we post-dilated, the waist disappears in the final angiogram. And again, we ended up using MANTA in this one. These are the echocardiogram. Very typical in our part of the world is to see these patients tend to have a lot of LVH that needs to be addressed. And the mean gradient is again 9, but bear in mind that these patients have LVH and we need to address it. Another case, again, 71-year-old gentleman. Now this one, the STS score is a little bit on the higher side, 6.3. This is the CT. You see a bicuspid aortic valve. Again, you look at the measurements over here. The height of the coronaries is okay. You look at the sinuses, again, fairly generous for our part of the world. And the peripheral vasculature is very good. I mean, you know, we're looking at 10, 8, 10, and 9, and 10. We went ahead and deployed this valve successfully. We didn't have issues. Closure device here was ProGlide, and the patient actually ended up doing well. This is the echocardiogram, short axis. You see the leaflets working very well, nice circular position, configuration of the valve that was implanted, even though it was bicuspid, and you see the gradient across the valve is 6 millimeters mercury. So what are our take-home messages is the demographics in the Gulf region have clear distinction, and we need to recognize that, and this is probably something worth evaluating in future iterations. The Myval platform itself, we have a rich experience, particularly here in this part of the world, and we reach the desired outcomes. There's limited data on the performance of the valve in complex populations, and I think our population in particular will help us understand how this valve performs and this technology performs. But it still warrants further evaluation, and as I said, we do have a Saudi FDA-approved registry ongoing.
Thank you very much. Khaled, I think it's almost time to wrap this up.
Sure. So we have seen from the presentations that we just heard now, the valve has a robust results from 2 large randomized controlled trials, Landmark and Compare TAVI. And it's short, intra-annular, and hopefully in the future can have feature of commissural alignment, which makes it a good valve for lifetime management. Has minimal foreshortening, which makes the positioning precise. It's crimped on the balloon, which can have advantage to somebody, and some people don't like it, but it is retrievable. And the leaflet design made the hemodynamics of the valve great. So I think lots of great features for this valve and for lifetime management when using this platform. Just to remind the audience, after this session, we have a live transmission from Prince Sultan Cardiac Center, mitral valve clipping.
Thank you very much.
Thank you.